I'm Rob Friesen, and I'm here in London talking with my friend and colleague Ted Sumner, one of the leaders of the of pediatric anesthesia worldwide during the last half of the 20th century. So, Ted, I have a few questions I'd like to ask you. We'll get to the journal, but I think we should start with your early life. Where did you grow up?
Well, I was born in 1940, the fourth child of parents. My father was an academic. He was a mathematician and professor of maths at Nottingham University, but he was also the world expert in the instrument, the organ. So he was a musician and mathematician, I think, which go together. My mother was a housewife and stayed at home and looked after us. And I had a very, very happy childhood. I was doted on by my siblings, and it was very nice. We had a lovely family. I went to school in Nottingham. It was a private school, but the fees were very low. My elder brother was there at the same time, and I didn't do all that well at school, and then I had an accident in the gymnasium at school and broke both my legs, and the gym master, I fell, he told me not to do it. I was climbing a rope, I used to love it, and I sort of did stupid things, and I fell off right from the ceiling height, broke both my legs, and the gym master came rushing up and said, "Look what you've done to the floor." And I was out of school for quite a long time, actually. So I was kept down, and so I did that year for the fourth year at school, which would be your 9th or 10th grade, would it? Something like that. I did that year twice, and that really was the making of me, because I consolidated and I became academic. So I did very, very well in all the exams, and I went to Oxford, and I went to Oxford initially to read biochemistry. And the tutor in Magdalen College said, "I'm not having somebody from my college going on to a course that's experimental." And he said, "You should do medicine." My eldest sister was a doctor. So I thought, well, I don't really want to do that, but if he says that's a good idea, that's what I'll do. And so I read medicine, and I did very, very well. I got a first-class degree in Oxford, and then I came to University College Hospital in London to do my clinical work. And I really enjoyed, well, two things. I really enjoyed the work with the anaesthetists, the anesthesiologists. They were a good crowd, and they were very keen on teaching. And I saw surgery as more of a technical thing, and of course it was very problematic in those days. The career structure was hopeless for surgeons, and a lot of them went to the United States. So I saw anesthesiology as a way of both enjoying a career, but also one that I might rise in it more quickly than if I did surgery. And during the training, I went to Great Ormond St for a year, and I really enjoyed working with the children, and it was quite primitive at Great Ormond St, I have to say, and but I enjoyed it very, very much, and I think I made an impression on them. There was one particular person, Sheila Anderson, who was a great person, and she was a direct protege of Ivan McGill. So I like to think that I was Sheila's protege and she was McGill's protege. So that was nice. And then I did my rotations and so on. And I was very, very lucky. And that's another thing that really made me, was I had 7 months pure adult cardiac surgery, anaesthesia for cardiac surgery, and adult intensive care at the Heart Hospital. And the as I was a senior registrar, senior resident, and there were 5 of us, senior residents, and 3 consultants, staff people, but they were never there. So we did all the work ourselves. And during the summer, 6 weeks, there were only two of us doing all the work, and we did it first on call and second on call on alternate nights for, I think it was almost 2 months. And nothing fazed me after that. However sick the patients, I took it in my stride, and we didn't have the inotropes in those days. We had isoprenaline, and we had adrenaline, epinephrine, and there was no dopamine or dobutamine. There were no offloading drugs such as enoxamone, and we had to play around with those to optimize the clinical situation. So at the end of that, I was competent to take on any sick patient, really. And then I was asked to apply for a consultant post at Great Ormond Street, which I did, and I was appointed. 1972. Well, things had changed. When I first started to work at Great Ormond Street, things had happened. So there were suddenly 22 gauge needles, where we'd only ever had 20 gauge needles. The only tiny needles we had would be metal butterfly needles, which were hopeless because they cut out and it would be a disaster. So that changed. One of the difficulties for me was that I'd beaten to the post several people that were still working there, and they resented it. They really did, and they lost no opportunity really to humiliate me. And I was determined in very, very short time to be absolutely the best technically that was possible. And I've always prided myself on my technical abilities. I remember very early on, I worked with a cardiac surgeon called Yarda Stark, he escaped from Czechoslovakia. He was trained in Boston. He was a very good surgeon, and in those days, Great Ormond Street had the best results in the world for the atrial correction of transposition, the Senning procedure, and for example, and I amazed Yarda. But we did a small baby truncus one day, and I put all the lines in percutaneously, which had never been done before. Nobody at Great Ormond Street had ever put an internal jugular line in. And there were these long-ish 20 gauge, I can't remember which make they were, and I put 3 in alongside each other into the internal jugular vein long before the days of triple lumen catheters. And that was quite early on. The first time at Great Ormond Street that there had been a small child having cardiac surgery, that all the lines had been put in percutaneously. The arteries they were used to cut down on the artery, on the radial artery, and post-operatively, if they were going to be ventilated, they would have a tracheostomy. And I stopped that. That was my doing as soon as we had Portex tubes. And I proved very early on, that you could, I managed one child with a nasotracheal tube for 10 months. But that isn't really the best thing to do. At some stage, you should do a tracheostomy because the kid can socialise more, and instead of being, But it sort of developed from there, and there was no really intensive care. the cardiac patients were all ventilated and monitored post-operative for as long as they needed to be, and that was fine. The neonates, the surgical, it was surgical neonate. We didn't have medical neonates because there's UCH just here, and that had a fantastically good neonatal unit. Osmond Reynolds ran that, a real pioneer in ventilating babies. So, and we didn't have proper ventilators. We only had those huge Engstrom ventilators. You probably remember those.
I do remember them.
And they were hopeless at ventilating. I mean, the lung damage we caused in small babies with those ventilators. There were some Bird ventilators, the American ventilator, but they weren't very good. They would stop suddenly, which was a bit alarming.
About the mid-1970s, the Siemens servo ventilator.
It wasn't Siemens in the early stage. It was a company called Elima Schönander, Swedish company. It was taken over eventually by the German company Siemens. Yeah, they made the servo ventilator. Of course, they developed it with a lot of input from people like you and me in terms of putting in, ventilatory assist modes such as IMV or EMV, and I suppose that's how it is now. I'm out of touch, but I think they still do the same. The other thing that was when was this business about ventilators. We only had those huge Angstroms, and there were no funds to buy new ventilators. The first two ventilators that we bought, I think there was a Seacrest. Do they still exist? No. They were a nice ventilator for babies, small babies, and then we bought the Servo, the Elima Schönander, but we bought two, and they came out of private funds. They came out of funds collected by the cardiac unit. It wasn't the NHS. They couldn't fund those ventilators, and sometimes surgery was limited by the number of ventilators we had. We used to have in the early days. I did ward rounds of the intensive care. All the patients being ventilated. They were all over the hospital and hard to keep a track of. So we had a book with it was a small book with leaves that you could take out, and then they go to be filed or used as research material. And so we'd fill the book in after we'd seen every patient all over, and so we knew where they all were. But we invented a fictitious patient that we would discuss every day and make progress on it. And the fictitious patient was called J. Reese, and his nose featured prominently in the therapies that were required for this patient. Anyway, he was a lovely guy. I was always in awe of him because he wasn't he the father of pediatric anesthesia, really, Jack Reese?
Most people consider him to be.
Well, he was probably, but certainly in the UK, but there would probably be people contending for that. And I was always in awe of him. But in his retirement, he went to Erasmus in Rotterdam. And taught, and I went to give. Anneke Mersing started an eponymous lecture in Erasmus for Jackson Reese lecture, and I gave the first one. And we bonded, Jack Reese and I, and he was such a nice man, really, and so really modest. really modest. And yes, so that was very nice, very nice. And I think there was always this rivalry really between the Liverpool department and Great Ormond Street, and in the early, when I started, there was no competition. With Jack Reese and Tony Nightingale and Gordon Bush and Eleanor Vivori, they were streets ahead of anything, and they had good surgeons. I mean, apart from cardiac and neurocrims and one or two of the specialities, general surgery at Great Ormond Street was terrible. Terrible. And they had good people. I mean, Jimmy Lister, he and I went on operating trips to Nepal together, and that was fun. We did the first tracheoesophageal fistula ever operated on in Nepal. Died. But anyway, and this was very early on. We had no monitoring. It was rare to put an ECG on even.
Yeah.
And it would be a finger on the pulse, a precordial or an esophageal stethoscope. We didn't have blood pressure cuffs small enough for children, and certainly no automated blood pressure devices. And I taught trainees to look in the wound, look at the wound, and see what does that look like?
Yeah.
And an American came over early on and said, "Oh, I admire your flying by the seat of your pants." But of course it was completely wrong.
Yeah.
It was terrible. It was 19th century. Jon Snow. David, we talk about David Hatch. I mean, David was an excellent person, and we got on very well. And I'd already collaborated, when I was a senior resident, I collaborated with a guy or a book about medicine for anaesthetists, and about chest disease and cardiac disease and thyroid, endocrine disease and stuff. And it was sort of logical that when we were asked to write books on various topics, that neonatal anaesthesia, I think, was the first one. It was logical that he and I would do it together, and that was very fruitful, I think, and they were good. Actually, the books, they were good, and David knew somebody who would. She annotated the documents coming out of the House of Lords, so she was an English graduate, and she sort of put them into good, clear English, and I think I learned from her, and that stood me in good stead for when I was a journal editor.
So you edited several books with David Hatch.
Yes, and yes, I did, and they were all right. It was the multi-author textbooks, and I think there's still going under our name, actually, but being edited. Although I'm not sure about that. They certainly went into 2 editions after we stopped doing it.
Yeah.
So I had that sort of literary thing, maybe, which did stand me in good stead for the journal when that came along. The other, the other achievement I really feel very proud of is the pain service, and I forget the year. I meant to find that out actually, but I think it was about 86 or 87. And I read an article in Anaesthesiology about, I don't know where it was from, but about somebody starting an adult postoperative pain clinic run by anesthesiologists, actually, I think. And I thought, well, that's what we should have. And I was very fortunate because the CEO of Great Ormond St at that time was an excellent person. It seemed like a golden age compared with what followed. Admiral, he'd been an admiral in the Navy, Admiral Sir Tony Tippett, and he and I got on very well, and I put forward this proposal And he said, yes, I shall find you the money. So we got enough money in perpetuity for a new staff member, which we then divided between two people, so they were part-time pain consultants too, and a senior nurse and a secretary. And that started. It started with acute pain management, and now it's huge at Great Ormond Street with all the chronic pain management too. So I'm proud of that, actually. But I had the help of both the chief nursing officer. She was a character called Betty Barchart. I was at a dinner once, and I had a beard in those days too, although I've had beardless years in between. And we were at a hospital dinner or something, and she came up to me and she said, oh, I like your beard. And she grabbed hold of it and pulled it so hard. I had tears in my eyes. Anyway, she was a good sort. And it was she who said, you've got to have nursing input. It's absolutely crucial. And it was Tony Tippett who saw the benefit and got the funding. And yes, well, Richard Howard, who he runs the pain service now, we appointed him as the new staff member.
You were head of the department for a while.
Yes, it was that time I was head of the department, but the head of the department at Great Ormond Street in anaesthesia is by rotation.
Right.
So it's 3 years plus 3 years if you want it. And I didn't want more than 3 years. But it was at that time that we started the pain service, because I had direct access to the CEO and the requests for funding and so on. So, yes, and I always thought that I don't want to appear sort of unpleasant and ambitious, but I thought we're already writing books. I was already looking beyond Great Ormond Street to have an influence or get influences from outside. And then I made such good friends with Paulo Busoni. Did you ever meet Paulo?
No.
From Florence, an unsung hero, really. It all happened with somebody from his department in Florence came to work with me to doing cardiac anaesthesia, and I showed him. They were starting a unit in Tuscany. So he said, "You don't do I've never seen anybody at Great Ormond Street putting an epidural in, or you don't do much regional anaesthesia." So I thought, well, no, we don't. But it wasn't my thing, but generally we did not do that. And so the odd caudal, maybe. The surgeons were very, very reluctant to have local blocks done on their patients. So this guy, Armando Salieri, nice person, I'm still in touch with him, said, well, you should go to Florence and see what we're doing there. And Paulo, such a nice person, and become a great friend. I stayed with him a week or two ago. He showed me what to do, and it would be unthinkable here. But he held my hand while I put an epidural in a 2-month-old baby. And show caudals, transsacral caudals. Have you done a transsacral caudal? If the caudal space isn't available to you because of infection or something, then you can do it transsacrally between these. And so I got really proficient, and I thought we should use this in the pain service. Continuous epidurals. In fact, he was already doing that, Paulo, and very early, and he never wrote anything up. And
so you brought that technology and technique back to Great Ormond Street.
Yes, I did. Yeah, and the older children, because some of the trainees, who'd worked in adult hospitals, they might put an epidural in for an older child, maybe, but we didn't have the equipment either. Portex. I don't know what it was like in the States, but Portex first of all made, really small sets that you could use. But before that, we'd pass any old catheter through as large a bore needle as you could possibly imagine.
Yeah.
But or an adult Suey needle, and then they wouldn't thread, and it was all a bit of a nightmare.
And you became interested in the leadership of the APA as well.
Well, yes. I mean, yes. We all were members of the APA, and they had annual meetings, and we hosted them sometimes, 2 meetings a year. One a sort of academic meeting, and then an annual meeting, and it was originally confined just to professional paediatric anaesthetists. Now, of course, it's open to anaesthetists who do children in district general hospitals, and that was a very good. We made a move to do that because they, of all people, need exposure to what's going on. And then I went up. I was a committee member, and then I was the president, and that was very nice. I enjoyed it tremendously. Then I was elected to be the president of FIAPA. It's not called that anymore. Federation of European Associations of Pediatric Anesthesiologists, and I did that for a very short time. I gave it up because I thought that it was unfair to keep on if I wasn't in clinical practice. There were I had personal things, 2 reasons I didn't continue to do that. But in doing so, I made, of course, an enormous number of friends. And a lot of people I'm still in touch with, people like Annika Mersing and Barbara Ekström-Jördal and Josef Holtsky and Martin Rawicz in Poland and the Italians and Isabel Murat, and they're all still friends of mine. It's very nice. So if I go anywhere, I always like to seek out the person I know.
And much of your friendships and associations with international anaesthetists came from your work with the journal. How did you get started working with the journal Pediatric Anesthesia?
Well, it was an idea that came out, I think, between Blackwell's. Blackwell's the publishers. They were the biggest journal publishers in the world in those days, and bigger than Elsevier, and now they're Wiley. But I think they had an idea. A guy there called Stuart Taylor had an idea. It would be because he was the head of the journal publishing, and he saw a niche or a hole in the market. But I think there were already ideas. Gordon Bush, a wonderful, wonderful person from Liverpool, and Claude Saint-Maurice in France. They got together, and Blackwell's, and Gordon picked an editorial board. And we had the first meeting in Paris, I think in 1987. And we chose the cover, we sort of planned the whole thing, and Blackwell's was, very professional, so they knew what to do. And so I was on the editorial board with Gordon Bush as the editor, and he'd chosen an international, I think it was the idea that with Americans, Nick Goodsouzian was on the editorial board, there was Isabel Murat, there were people, I think, it's early onset, or maybe not very early onset dementia. Rob Ayres from Melbourne, and so the idea was that to have an international editorial board, therefore it would sell in all the English-speaking countries. That was the whole idea, even in the United States. So that's how it started. Gordon, I think his idea was to start the journal, and it was always his idea. He told me that I would be the second editor. He would establish it. 3 years he stayed as editor, and then I became the editor. And it was a very uphill and fast learning curve. It was always my idea that we'd have an editorial and then a review article, and there were all sorts of tidbits, you know. Nick Gutsusian was very keen on having little historical
Yes, I remember
anecdotes or something, and I really like that. But the problem as I saw it with the journal, and Blackwell were always on at me about it, was the impact factor, and of course, you can only raise the journal's profile by having good papers, and a lot of the papers we had were not, not good. No, it was almost no pure science, and in the United States, you're quite ruthless, and I mean that as a criticism. The established journals in the United States, which are of course very fine journals, Anaesthesiology, the best anaesthesia journal in the world, and Anaesthesia and Analgesia, a very close second probably, and they immediately started. Well, I think Anesthesiology always had a paediatric section, always did. But then as soon as that paediatric anesthesia came out, A&A also started one. And no, I'm not going to say what I was going to say. It's too indiscreet, unless you want indiscretion. Don't turn it off your mind. I'll tell you off camera.
But that's a problem that most beginning journals have.
Yes.
Is
and so,
impact factor, poor quality, or less than desirable quality at the beginning. But this changed over the years.
It did change. It did. And I tell you, we worked incredibly hard. But so we were up against it, really. And then I thought, well, maybe we'll try and we'll try and get some pure science papers and get lots of citations. But then I thought maybe it'll be we can promote it as a service to other countries, and I started because I could have, I think, 12 free copies as editor, and monthly free copies. I used to donate them I sent them to various places, my free copies, to places in Africa, India, Japan. I forget where they all went.
They didn't have many other opportunities.
No, and I used to go to a lot of meetings, and of course we usually had our editorial board meetings associated with another meeting, bigger meeting, and I would listen to the talks, and I'd go up to people and say, I really like your talk, put it in an article. So I did a lot of that, and I made overtures to people whose first language was not English, and I always made a point of saying, look, if the content is nice, I'll put it into and I made a point of that. I regarded that was one of my most important jobs as the editor, was to make these articles readable in English, and I always felt I had very high standards of English, and I kept on with the journal until long after I retired. 5 years, I think. But it was the thing I enjoyed the most of all my career. I had this wonderful network of colleagues all over the world. I felt I was doing a good job.
Any final thoughts about the future of pediatric anesthesia, or any other thoughts about your career?
What I'd like to say is really how incredibly fortunate I feel for having grown up in that era, in that it was easy to innovate. You could see what needed to be done.
Mm-hmm.
The manufacturers were very good, actually. You get them on your side and they would make things for you if you needed it. And David was very good at doing that, Hatch. And nowadays everything is very, very regulated, and which is good. It's good. I mean, standards are very high in the NHS here, very high, and but I think it's less fun. Maybe I'm criticised for overusing the word fun, but yeah, it was fun, and we had fun.